I want to say good afternoon, but since we're recording it in the afternoon, but you're listening to me in the morning, so good morning to all of you. Thank you for this opportunity to present some programs about hospice. Personally, I would prefer to be there face-to-face with you, but since I can't bilocate yet, I guess we'll have to do it this route by way of recording. You already know my name, Tom Welk. I'm Director of Professional Education at Hynes Memorial Hospice. Personal background, if you're trying to figure out my accent, I'm not from this area. From North Dakota originally, and English is not my first language, German is. And my involvement with hospice has been, now this is our 40th year, and I span the entire history of hospice. This is work that can be very challenging, but also work that can be very satisfying. I regret the fact that I was not able to be present with you at your church. And unfortunately, I can't interact with you and you can't ask me questions. So hopefully I'll be able to answer the questions that might be in your mind, and if down the road it works out, I'd be very happy to come and be with you with your congregation. We have a 4-part series coming up. This first part we've entitled Myths About Hospice, and I've got 5 of them outlined, but I know there's many, many more. Especially when we first started, there was a lot of misconceptions and misunderstandings about what hospice is about. A lot of people couldn't even pronounce the word. As you look at how it's spelled, Hospice, we heard a lot of hospice around there. Out there in the front of our office, we have a sign about hospice. Actually, somebody stopped in one time and asked, what kind of spices do we sell here? Well, I was tempted to say burial spices, but I refrained. I didn't do that. One of the things that invariably come up, not as much as initially, but people figured out what we're about in hospice care, that we take care of people on the last part of their life's journey, a very important part of their life journey. And so you can pretty well guess, if you played word association, they ask you hospice, I throw that word out, and the response almost invariably is death, the next word. And you got to say it with a somber ring. I try to dispel that immediately. If you have a program on Hospice 101, I think the very first thing we have to make very clear is that we are not a program about death. We're not a program about death. The funeral business industry takes care of that aspect of it. We are very much a program about life and about living. Yes, these people know that they don't have an unlimited amount of time. They know that most likely than not, it'll be within a relatively short period of time. But these people really very much engage in living that last part of life's journey as fully and as well as possible. And truth be known, I've encountered many a family and many a patient, more likely, where they probably now lived more fully that last part of life's journey, be it whatever time, 6 weeks, 6 months, they may have lived their preceding lifetime, because now they had to get things in order. They had to put priority to what was going on. I kind of tease around a lot regarding the question about the whole process of living and dying. Ask people, and they catch them off guard. They say, what's the mortality rate for every generation? People kind of scratch their head and they struggle with it. I asked that question one time. I was doing a program at one of the hospitals for family practice residents, and this young man, he thought he'd really impress his peers, and he asked a question, what's the mortality rate? He said, well, I think it's about 67%. Of course, that raised a good bit of a chuckle in the room. Fact of the matter is, and this is not church time, this is not religion time, this is science time. We all know that the minute we began our physical existence, we began, if you want to frame it that way, the dying process. Our ticket's been punched. It's been said before, that birth is a mortal disease. It's a terminal disease. So you and I this morning woke up, hot day again as we're recording this, beautiful sunshine and the clouds were still around, it wasn't hot yet. So that we wake up this morning, it's a beautiful day, and then the next line we would say, yeah, but I'm in the dying process. If you want to frame it that way, fine, but I prefer to say I'm in the living process, and I want to live life as fully and as well as I can today. So the mortality rate, yeah, is 100%. But let's also say that the living rate ought to be 100% for us. That every single one of us ought to do what we can to meet the challenges of living fully. And when it comes right down to it, I want to be honest about this also. If I'm compromised with a terminal illness, whatever it might be, say cancer, it's going to be very difficult for me as an individual without help and without support to live that time as fully and as well as possible. What I will need is help and support to do so, and that's where hospice fits in. I really cherish the 40 years that I spent working in hospice, and I've really learned a lot about life and about living from the patients and the families that I've been honored and privileged to be a part of. And what I do, and I say this not without any exaggeration whatsoever, I never leave the home of a family or patient I visited. They usually want to express appreciation and thank you for whatever help I gave. But I always say in turn, thank you for the honor and the privilege of you opening your home for me, opening your hearts and your life to me. You've enriched me also. So it's a mutual kind of relationship. I call it reciprocity. The word hospice comes from the Latin word hospes, hospitis. And it doesn't simply talk about the person who provides care and support, host or hostess. It really talks about that reciprocity, the gift we share with one another by the very fact we interact. So once again, just to sum up with regard to this first myth that hospice is about death, about dying, not at all, not in the least. It's living, and it's living fully, the very sacred part of life's journey. Another comment I think in the back of my mind, I often feel that as I walk into a home where this is happening, this transition, that I'm walking on holy ground. It's sacred ground. I almost feel like I ought to take my shoes off when I come in. And of course, in some cultures we do that, especially the Asian cultures, because these transitions times are healing times. They're holy times. It's the same word basically from the Anglo-Saxon. At this point, I would have opened it up for questions for you, but sorry we can't do that here in this kind of setting that we have here today. The other myth, kind of a more dangerous one that people have out there, and I still can't believe that I keep hearing this over and over again, that hospice kills people. Sorry if that sounds harsh. That we are people that go out there and we put people to death. Not in the least. Nor do we hasten death. Sum up very quickly what we really have in terms of the philosophy of hospice is very simple. We don't prolong the dying process. We don't drag it out. In effect, giving life-saving drugs and life-saving interventions, because these individuals are at that point where it's not going to fix their underlying condition, whether it be heart disease or a cancer or Lou Gehrig's disease or whatever the case might be. While I'm on that, by the way, another myth that I don't hear anymore, but we heard it when we first started the first program in Sedgwick County in 1983, is that hospice is only for cancer patients. Not true at all. The key is not the diagnosis, but the prognosis. And what Medicare really insists on is that two physicians have to certify, usually the attending doctor and one of our medical directors, that this individual has a terminal illness. I may be wrong as I'm saying that. I think it may only be one doctor to certify, but not that it's overly important. But in effect, it's the prognosis. And Medicare says 6 months or less is the expected time frame. Someone lives longer than that, fine. But we have to document that their decline is still downward. It's just not going as quickly as is the case. When I deal with physicians, that question is often brought up, whether or not they have to be absolute in that guess about the time frame in terms of living. And the best way I can explain it to them is I ask the question, would you be surprised if this patient of yours ends up dying within 6 months or less? And say, oh, no, not at all. Then you can sign, you can certify that they're appropriate for hospice. So once again, it's not the diagnosis, it can be anything, not just cancer, as we heard invariably 40 years ago. Anything the doctor says this person has had going on for a while, they've tried the curative, it's not worked, they're at that point where nothing will work. So in effect, the prognosis is what we're looking at. I look at this question in terms of the medical community and how they interact with hospice, and again, when I first started this work, there was some resistance on the part of the medical community. They didn't really want to acknowledge that this patient of theirs would not be able to overcome whatever is challenging their life. And I think the reason for that being that if you look at medical professionals in general, physicians in particular, why did they go off and get all the education they have and all the training and all the expertise they have? They really focused on all of their education and training on saving life. If I'm sick, if I'm compromised either with a disease or with some kind of trauma or injury, the medical community is very, very good at being able to overcome that. We have marvelous and almost endless medical interventions. This is where a patient now is what I call in the sick role. There eventually comes a point where nothing is going to work anymore. What we really have to acknowledge is this patient is now on the part of the life journey that I call the dying role. And the dying role doesn't mean we've given up, there's nothing more we can do. In effect, in the dying role, a lot of living still goes on. So I don't want that misunderstood now that there's a giving up. And I've had to deal with a lot of physicians too who, if I just illustrate this point with an example for myself, say, I now have a doctor that I've told very clearly, if things really get to the serious point where whatever ails me, whatever threatens my life cannot be gotten rid of, I want to know. So I've made that very clear. So it comes to the point where I'm not feeling good and I go to my physician, he takes the tests and they come back, it's pretty bad what I have, say a cancer illness again, and there's nothing really that will work. So the tests are done, I come in, he shares the news with me, and probably I'm nervous about it already. And doctor shares, if you will, the bad news with me, and he says, but you're such an expert, you can take care of that. Remember, I've told him, I want to know. So the doctor insists, and finally he gets to the point where he says to me, Tom, there is nothing more we can do. Now that sounds okay on the surface, but think about it on the part of myself as the patient. Here I am, as I said earlier, I'm in a very important part of my life's journey. I have a lot of living to do, a lot of things I want to have taken care of. And here's a doctor telling me, a very key player in the support I need, what I said earlier, a doctor telling me, Tom, it's adios, goodbye. I feel very much abandoned and neglected. What the doctors need to do, and I tell medical students this, change the focus of your comments. It's important how we frame things and the words we use. The man says, Tom, aggressive curative treatment is not going to benefit you. Matter of fact, it might do more harm than good. We will not abandon you. What we're going to do is change the focus from aggressive curative care to aggressive comfort care. And I will line you up with a program, a hospice program, that specializes in taking care of you, supporting you so you can live whatever you have left of life, live it as fully as possible to the very last minute. That's what I'm talking about, this movement from the sick to the dying role in terms of medical intervention. We get referrals way too late in our program. I think every hospice program will tell you the same. The greatest number of patients we have in our program are patients that are with us 2 days. And the reason for that is that the medical community is so good in terms of the sick role, it almost finds it impossible to move now a patient to the dying role. When you're looking at 2 days in terms of the care that's required, we really can't do a whole lot in the hospice program. And so many of patients and families, above all families, have told us, we wish we had called you sooner. We wish you had called you sooner. Let me illustrate this whole point about why it's so important to call sooner. I had a particular patient that I visited for the very first time. I made my visit. And as I walked into her room, first thing she said was, thank God for cancer. Think about that for a minute. So if I were with you and I was asking you for an answer, what would you come up with? A lot of people come up with different answers. One of the things that we need to keep in mind is the duties of the dying role. The duties of the dying role. So let's say, for example, here I am moving along in a very even keel in life, and I get into a tragic car accident, I'm gone. Precipitous fall, death here. Or I have a heart attack. Again, the same thing, even keel, I'm gone. There's no time to take care of the duties of the dying role. So what was this woman saying to me? She had her cancer, she did her aggressive treatment, some decline. Doctor finally said, we can't fix it. She's not going to die immediately. She's going to have more of a slope, right? More of a slope. She had a lot of issues that needed to be addressed, particularly with loved ones. A lot of dysfunction going on, for lack of a better word. So myself and the social worker worked with her. We were able to take care of the kind of things she needed to have addressed. And you can probably guess what happened. When we had, again, facilitated the reconciliation between the last one that she identified, what happened in short order? She died. Within a day. She had done the duties of the dying role. She was able to move on. With regard to this second point about hospice hastening death, we allow death. We don't cause death for people. It's the underlying illness that brings about the death. And truth be known, I knew this real early on in our program with a particular patient we'd under care, and I still can picture her, I still remember her name, but obviously I can't share that in a public sort of way. But I got to know this patient very well. She had a very aggressive disease, lung cancer. And at that time, we still were using the media for getting the word out about that we're here, take care of people in the dying role. And so I had a photographer and a reporter come along from a TV station. They asked her all kinds of questions. And this woman, when she was diagnosed with this lung cancer, she had foregone every medical intervention on curative basis. So the reporter asked her, if others were in your position having the same situation, would you advise them to go to hospice? She didn't even let him finish the question. He said, go, and go immediately. And she asked him, well, why? And she says, we always go with hospice. People are able to live better, a higher quality for that last part of life's journey. She says, not only would people live better, but they would probably live longer. And she was absolutely right. Now, I don't in any way want to disparage the aggressive curative treatments, example for cancer, but the fact of the matter is there's always an up and a down to those aggressive interventions, isn't there? And so we hope the balance is the benefit outweighs the side effects, the whatever else ails us in terms of that. But if you cannot reasonably expect that this is going to end up doing you well, then I would say very categorically it's almost unethical to provide that aggressive curative intervention, because we are going to compromise the ability of that person to use that energy to live life fully. It's a very painful, difficult wrestling that goes on with regard to that particular question. So I've known this anecdotally for many, many years. So I'm kind of gratified that the researchers have come up very clearly showing this very same point, that if it's, again, a particular disease that's not going to lend itself to cure, we're much better off providing aggressive comfort care. Another fancy word to use is to provide good palliative care. Good palliative care. We know that it's difficult. We find that people find it very difficult to move from the sick role to the dying role, and that's why we get such late referrals. What we have started here at Harry Hynes Memorial Hospice is a bridge program. We actually call it that, a palliative care program, that we get involved now with people who are still going through the curative treatment, the sick role, but doesn't look like they're really going to overcome it, but they still need a lot of comfort care. And so it's a bridge between the aggressive curative, the sick role, and the dying role, which is aggressive comfort care. So again, I'd offer you time for questions, but once again, not being face-to-face, that would be impossible, so apologize for that. Touching on this third myth, it always almost ticks me off a little bit when people say, well, I had a loved one or I knew of someone and they got involved in hospice and they just died like that. They killed them. And how did they kill them? Again, using some jarring language there, they used morphine. Morphine does not in and of itself kill. They said, well, that loved one of ours, they gave him morphine and he slept for 2 or 3 days. I'm exaggerating me a little bit. Why did their loved one sleep so long? Was it because of the morphine? Yeah, maybe indirectly. But they may have been in so much pain they couldn't sleep for a week maybe. So now finally they're comfortable. And what are they going to do? They're going to catch up They're going to catch up on all the sleep that the pain or the troublesome symptom robbed them of. I worked with a lot with our medical directors, particularly a number of years ago when we do joint programs. And I wish he were still here. I've tried to talk our pharmacists to coming in and give that. So I'll give you the amateur version about morphine. It does not kill in the right amounts when it's used. Titrate it carefully. And our nurses and our doctors are skilled at that. They're not going to give someone who's morphine naive a high dose, say 200 milligrams. They maybe start them on 2 milligrams and then work up. So this is the way you titrate the medicine, a fancy word, that you go to the level where the patient says he or she is comfortable. Does it suppress respiration? That's what's out there. I'm not a pharmacist, I'm not a physician, so I just simply want to give you the lay version of how I understand it. That when you're looking at this, it opens up all of those ways in which we have exchange of oxygen in our lungs. It opens up those vessels. So rather than having it suppress respiratory function, it actually alleviates it. And I talking with a doctor one time whose mother was under our care, who was very reluctant in terms of the morphine. So I had the nurse explain it to him, and his mother got so comfortable, was breathing easily, not air hunger, which is frightening both for the patient and the family, but was able to get very comfortable. And eventually when she did die, she wasn't dying in terrible pain, writhing in pain with that troublesome symptom of air hunger, but she died very comfortably, very peacefully. So that's what morphine is about. It really enhances the care that we provide. And there are so many derivatives of that. Again, I'm not going to bore you with all of the different medications. By the way, just a little background. Medical language is not difficult for me. I had 7 years of Latin. I had some Greek. I actually taught Greek. And so when families say, well, the doctor gave me that, and I was just visiting yesterday with someone, the doctor was talking in gibberish to me with medical language. And they often want to say, it was Greek to me. Well, I tell them, it was Greek. It was Greek. It was Latin. So if you know Latin, you know Greek, this is not difficult language. So once again, I'm not going to bore you too much with that. I forgot to mention at the outset of my comments that my work, my educational work, I have a degree in philosophy and one in theological studies, which really prepared me a lot for my later degree, doctoral degree in medical ethics. So I deal a lot with medical ethics. One of the things that I want to say with regard to this whole morphine question, the goal we have is to make a person comfortable. And say, for example, whatever the opioid might be that's going to be given, if perchance it could hasten the death of a patient, that is ethically sound, what we call the principle of double effect. And intention is so very important here. The intention that we have in mind is not to cause this person's death. Our intention always is to keep that person comfortable. And if perchance it may take off some time from that person's life, that's ethically sound. And having said that, I want to go back to my original point. I don't think we really have to fear that, because in the hands of a skilled provider, morphine is not going to cause the death of that person. So again, just to sum that up. When I first heard this third myth about hospice, is that you get into hospice and it's going to take away all your money. They're going to take away all your money. I said, where in the world is that coming from? And I think I figured out that at CMS, Centers for Medicare and Medicaid Services, say if someone is trying to hide assets for their loved one and say, for example, get them a long-term care facility or whatever, and then the person dies, maybe they will come to have Medicare or Medicaid, will want to have reimbursement for that, so that you cannot hide those assets. That's the only thing I can figure out. No, we do not come in and take the patient's and the family's money. The payment system for hospice is very simple. It's almost coincidental that when we started Harry Hynes Memorial Hospice, we started as Hospice of Wichita in 1983. That was the same year that Medicaid, I forget what it was called. Today it's CMS, not that it's important. The Medicare system put in the hospice benefit, and the Medicaid system, the same thing. So we were the first program in Kansas to go ahead and do all the necessary work to become certified by Medicare so that the patients we cared for would be able to access the Medicare hospice benefit. We were the first program in Kansas to have that. And basically, all the expenses that are involved in hospice care are covered by the hospice benefit. Commercial insurance, we had to fight tooth and nail with the commercial insurances in Kansas to make sure that insurance coverage would have the hospice benefit. And commercial insurances, by and large, almost 100%, will clearly follow the Medicare guidelines for hospice reimbursement. So again, if you're not Medicare or Medicaid eligible, the same system applies. And that system is we get paid a certain amount of money each day to provide for the patient who is eligible. And that's not a huge amount. I don't know exactly what it is. It's right around $200, I believe, for routine home care. Out of that payment, the hospice program has to cover the medications related to the terminal illness, all the durable equipment from hospital bed on through, all the staff visits, and then also bereavement follow-up. You can just imagine that the $200 is not going to stretch very far, but you get paid that $200 regardless. What ends up happening is that sometimes a hospice program, especially in the for-profit arena, may likely go the route of maybe not spending as much on the patient so that more money can be put into the investors, the stockholders, or whoever the owner might be. This is not what we're about at Harry Hynes Hospice. We want to make sure that the bottom line isn't what income we can generate. Even though we need to do well in order to do good by patients, let's say it honestly too, but our function, our goal, our mission statement doesn't say let's make as much money as we can. Our mission statement always has to say the bottom line is the patient care. And I can assure you, one of the things I say very loudly and very clearly here at Harry Hynes Memorial Hospice is there are two hallmarks that I'm never going to allow to be compromised. Number one, quality of care, and secondly, the care done with integrity. And that's what we're always going to stand by in terms of our particular aspect of making sure the resources are there. Just a further little comment about the whole question about the difference between one hospice program and another. I don't know what the count is. I'm going to learn here. Melody, count in terms of hospices right now might be 26 or so. Are we still the only community-based hospice in the area? So again, just to make sure that that's understood clearly. We started as a community-based hospice. We continue on that. Our board of directors represents the community. They make sure we stay true to our mission, and that's how we're going to continue. And the community has been very generous to us in terms of providing for whatever shortfall we may have in terms of third-party reimbursement. When it comes down to it in terms of, I don't want to say too much about the distinction, but I think the frontline staff on the for-profits part are pretty dedicated people, try to do the best job they can. I'm more concerned with what happens in terms of the ownership. So I'm going to say that very loudly and very clearly. And for example, my own personal involvement, I don't consider it a job or a career. I consider this really my vocation, my mission, that I'm really wanting to do the best I can with regard to what we are. Continue on this same point. Another myth that's out there is that Harry Hynes Memorial Hospice is a part of the Via Christi, the Ascension Via Christi system. And my guess is that that's out there because we have a very, very dedicated and very compassionate unit that is housed at one of the Via Christi facilities, St. Francis, on the third floor. So patients that are at that point where they have acute needs, above all in terms of pain control and symptom management, we provide a hospital setting, a hospice hospital, where we have 24-hour RN, 24 access to physicians, so that if a patient is so terribly uncomfortable, we're able to manage that and keep our eyes on it on a 24/7 basis. That's where I think this myth comes that we are part and parcel of the Ascension Via Christi system. We are not that at all. nor are we part of any medical group. We are a freestanding hospice, not affiliated with any medical or any faith community, to make that very clear. Which leads to the other myth that's out there that somehow, some way, we're part of the faith community, Christian community, part of the Catholic Church. Now, I think I'm pretty clear as to where that comes from. I'm a Catholic priest. I think you all know that. And I think I am often identified with Harry Hynes Memorial Hospice as one of the founders. And so people automatically take the next step. Well, you must only be for Catholics. Not at all. We are non-denominational. We are not connected with any faith community. As I said earlier, not a medical community. We take people across the board. And I make very clear to our chaplains, when I hire a chaplain here at Harry Hynes Hospice, they are hired to provide spiritual support. And I make it very, very clear that there's no proselytizing, no attempts at convert making. The patients and the family direct us in terms of what they want. Many of our patients, obviously, are going to be connected with the faith community, with the church. And so they're going to turn there very naturally. We can either partner with the pastor, go work hand in hand, providing the spiritual support, or we can simply let the church continue to do that. We make that assessment. Often it is a partnering. And if there is a particular challenge that our chaplains can handle with their expertise, I think that's a good partnership for us to be involved in. As for my involvement, a lot of times there's a sacramental ministry I'm able to provide for patients and families of that background. So I'm more than happy to do that if they don't want to go to their particular parish. Spiritual support versus religious support, hard to differentiate. I think that the question of spirituality is a tough one that I'm going to, again, if we go to the next session, get into more detail. But I think religion is very, very important to meet the spiritual needs of patients and their families. If you want to follow up on further information, I would be glad to take a call at the office. You may have just individual personal needs regarding the possibility of having someone involved in our program, so don't hesitate to do that. You can also go to our website, hynesmemorial.org, and it'll give you lots of information regarding the facts about our own program, the Harry Hynes Memorial Hospice Services, answering questions like, when is hospice appropriate? What can we do? Even a section on volunteers, on grief and loss. So again, there's a lot of information available there. Thank you for this first session. And so we started with myths about hospice. The next session I'm going to talk about, here are the hard facts about what we do in hospice. Thank you for your attention.